Yes, I'll do that. Rizwan, it will be great if you can share your screen for the time being with the flyer for this YPF Journal Club presentation. Dr. Puneeth Babu, we have made you a co-host just now for this meeting. We would just like to do a AV check whether you're able to share your screen or not. So can you please just share your screen so that we are able to know that everything is fine? Yes. Can you just go flip through the slides so that, okay, fine.
So I think you can leave your first screen on. Yeah, that is perfect, Puneeth. So we will wait for the chairpersons to come in, and once we introduce the chairpersons, they will ask you to, they will introduce you, and once you are introduced, you can begin.
Dr. Rizwan, I would request if you can guide the chairpersons to introduce the speakers, because I don't know whether they know this or not.
Yeah, I have shared the program schedule, and I would once again request them. So yeah, thank you, Dr. Ekaj, for the input. I will definitely guide them through.
Thank you, Dr. Rizwan.
Dr. Ekaj, I hope the journal club would have been like the recording is going on. I guess you are
The
doing the
recording is going
recording.
on. The recording will be available once the session is over. By tomorrow, the recording will be available.
Great, great. Thank you.
So while we are waiting for our chairpersons to join, I would request everybody to please, for once, just few seconds, switch on your videos. We want to take a group picture of all the participants. Please switch on your video. Puneeth, can I request you to stop sharing the screen so that we can have all the pictures on the main screen?
Dr. Puneeth Babu, please stop sharing your screen.
Sir, I think I've stopped it, sir. Isn't it stopped, sir? One minute.
Still sharing.
Right. I would request all the participants to please open your videos. We'll have a group photograph. And I take this moment to welcome Dr. Debashish, President-elect ISTM. Our chairperson, Dr. Harish Warbhe, has joined us. So I'll be, again, Dr. Sanjay Avachat, please switch on your video if you can. Okay, so in 3, 2, 1, we'll have a picture. I'll just click the screenshot and then we'll share it with each one of you. So it goes, here it goes. Let us hear for YPF. It's 3, 2, 1. And this is the first screen. This is just the first 30 people. Please do not switch off your video. I really appreciate everybody who has joined. So we'll need to take many screenshots. This screen has so less pictures. Dr. Abel, Dr. Palvi Singh, Dr. Lavanya, Dr. Shubhangi, Dr. Basant, Dr. G. Shanti, Dr. Sumati, Dr. Lathav, Romesh Jain, Dr. Shrestha, please, Dr. Parvati Mohan, please switch on your cameras. We are posing for a picture. This is going to be the new craze. Rather than a selfie, we'll have web fee, if that is something. We can see the ever smiling Dr. Satyam, who has joined us. So let's hear it again for YPF. Let me just figure it out. Yes, exactly now. So in 3, 2, 1, another screenshot. Wonderful. There are a few more to go. I love this. We have 5 screens of participants. I don't know how we are going to take them all, but we definitely will. Going to the next screen. Oh, it's again without videos. Dr. Palvi Singh, Dr. Sumati, Dr. Divya, Dr. Santosh, Dr. Shami Shastri, Dr. Seema Dua, Dr. Praveen, Dr. Sajita. Please switch on your Dr. Pandeep Kaur, Dr. Paramatma, Dr. Divya, Dr. Parvati Mohan, Dr. G. Shanti. Please switch on your cameras. Please switch on your cameras, everybody. Wonderful. So we have now 93 people right now. We will repeat this exercise once before we end it. So Dr. Puneeth, Dr. Harish Warbhe has joined. I would request if you could make him the co-host.
Yes, sure.
We are waiting for Dr. Archana Bajpai. And Dr. Puneeth, can you please make Dr. Debashish the co-host?
Sure. So Dr. Warbhe sir and Dr. Debashish sir both are co-hosts now.
While we wait for Dr. Aparna, we would request our President-elect ISTM, Dr. Debashish, to say a few words.
Okay, I think we have crossed the century mark. Okay, good evening, everybody. Now, where is Dr. Aparna is yet to join?
So ma'am will be joining and ma'am is here. She couldn't have a longer life. Ma'am is here. Dr. Aparna has joined. Dr. Puneeth, could you make her the co-host, please?
Sure.
Dr. Aparna and Dr. Harish is there. So I think as a chairperson and the co-chairperson, so we can now start the program. Yeah. And I'm sure we'll all have a very interesting 2 topics which I will discuss today. And we'll all enjoy this academic session.
So without much further ado, this is a Young Professional Forum ISTM academic initiative. This is the first journal club, and I would thank Dr. Puneeth Jain and Dr. Rizwan Javed for, being at the helm of the affairs. I hand over the mic to you. Please take it on.
Yes. So I would just request everyone to switch off their cameras now, since we formally begin with the program. And I would like to invite Dr. Rizwan to introduce our chairpersons for today, and we should begin with the program. Thank you.
Thanks, Dr. Puneeth. Good afternoon, everybody. Welcome to our first Young Professional Council Journal Club, and it is a pleasure to have Dr. Harish Warbhe from Lifeline Blood Bank, Nagpur, and Dr. Aparna Mukerjee, who is a scientist at the Indian Council of Medical Research, to be the chairpersons for this session. We welcome you both, and we would like you to take over the present and invite the speakers subsequently. May I request Dr. Harish to introduce the first speaker for the Journal Club?
Thank you, dear Rizwan. Thank you for honoring me and my co-colleague, co-chair as a chairperson for this Journal Club. I must thank the Young Professional Forum and ISTM for taking this very beautiful initiative of conducting the journal clubs and instilling the academics in the our fraternity. The first speaker, rather the presenter, is Dr. Puneeth Babu Ani. He's from AIMS Jodhpur, and the paper is like hypocalcemia and traumatic coagulopathy and observational analysis. Over to Puneeth.
Thank you, sir. Thank you for the warm welcome. Good evening, everyone. This is Puneeth, Senior Resident in Department of Transfusion Medicine from AIMS Jodhpur. Today, I'm going to present on the hypocalcemia and traumatic coagulopathy and observational analysis, which is a paper which is presented in, which was published in Vox Sanguis this year. So hypocalcemia, the clinical question which this study was trying to answer is, does ionized hypocalcemia at presentation in patients of acute trauma cause coagulopathy and mortality? As we all know, hypocalcemia is a known risk factor for coagulopathy, and transfusion, especially with the new massive transfusion protocols and all, it is associated with hypocalcemia. So the question which these researchers were trying to answer is whether ionized hypocalcemia is present before the patient is taken up for brought into the ET or emergency, or if that hypocalcemia is actually causing coagulopathy and mortality. So globally, 11% of the mortality is associated with trauma and its associated diseases and its associated conditions, and 25 to 35% of injured civilian trauma patients have deranged coagulopathy on arrival. These are based on previous studies, and as we all know, the most common kind of coagulopathy which we all know is about the resuscitation associated coagulopathy, which occurs as a result of transfusion of blood components, including PRBC or FFP. And this results the decreased metabolism of citrate and the increased number of coagulation, increased number of citrate through the various number of components which are transfused results in a resuscitation associated coagulopathy. But the less studied part, which is the acute traumatic coagulopathy, is now a focus of our attention, which occurs even before the resuscitation process starts. And it has been named with, it has been known by various names, by like trauma-induced coagulopathy, acute traumatic coagulopathy, and early coagulopathy of trauma, because it happens even before the resuscitation occurs, and the acute coagulopathy of traumatic shock, or ACOTS. So the various, out of all these, the most commonly accepted terminology, that is trauma-induced coagulopathy, occurs even before the resuscitation-associated coagulopathy, and as a result of hyperfibrinolysis and hypercoagulable state, which occurs as a result of this traumatic event. The resuscitation-associated coagulopathy, as you all know, occurs due to the dilution, acidosis, hypothermia, or a consumption of the coagulation factors, together resulting in the known phenomenon of trauma-induced coagulopathy. The acute traumatic coagulopathy. So the first thing which occurs is the trauma, which results in the tissue injury, and this tissue injury itself results in a release of a lot of procoagulant substances, and the activation of the coagulation pathway along with the fibrinolytic pathway results in a phase of hyperfibrinolysis and hypocoagulable state. So this, coupled with the inflammation along with the loss of coagulation factors, which occurs due to the acute blood loss, as well as the acidosis and hypothermia, which occur as a result of the trauma, together result in the phenomenon known as trauma-induced coagulopathy. So the hypocalcemia in trauma which occurs is also one of the factors which can result in trauma-induced coagulopathy. So this is what the researchers wanted to study, and this hypocalcemia in trauma could occur due to the loss due to hemorrhage, consumption during hemostasis, impaired calcium hemostasis due to trauma, increased sympathetic activity, the blood component transfusion itself, as well as acidosis. So these causes of hypocalcemia can result in a decrease in platelet function, and decrease intrinsic and extrinsic coagulation pathways, and a decrease in cardiac mortality, which can exacerbate the shock, as well as the decrease in availability of coagulation factors at the site of injury, calcium-dependent physiological and biochemical processes, which are also impaired due to this hypocalcemia. So the aim of this study was to identify the incidence of admission ionized hypocalcemia in major shock traumatic patients. And their primary hypothesis was that there was an association between the ionized hypocalcemia, coagulopathy, and mortality at hospital discharge. So the study was a single-center retrospective observational cohort study, which was done in Alfred Hospital and Royal Melbourne Hospital in Australia. And the data was collected from the patients who were admitted during the period of 1st July 2014 to 30th June 2018. And the data was extracted from the Alfred Health Trauma Registry and Alfred Health Applications and Knowledge Management Department. So as we all know, retrospective data has a problem of not having the whole data in it, whatever is required. So the missing data which was there from the trauma registry and knowledge management extracts were manually reconciled and incorporated from the medical records. So the study was reviewed and approved by the Alfred Hospital Research and Ethics Committee. And the inclusion criteria were patients with an injury severity score of greater than 12 or death after injury, and admission to ICU or for more than 24 hours with mechanical ventilation, partial or full thickness grafts greater than 20% of the total body surface area, or those patients requiring urgent surgery within 48 hours from arrival, such as those with, for craniotomy, posted for craniotomy, thoracotomy, laparotomy, pelvic or spinal surgeries, or undergoing interventional radiological procedures. So the patients aged less than 18 years of age, or those presenting with a shock index of less than 1, were excluded with the study. Patients that were transfused red cells prior to hospital presentation were also excluded, because these patients are more prone to transfusion-associated coagulopathy, which is already a well-known phenomenon. So the sample out of around 15,547 patients who were registered in the Alfred Hospital Trauma Registry during the study period, out of them, 12,264 patients were excluded because they were not of major trauma or age of less than 18 years. Of the remaining 3,283 patients, around 429 patients were excluded because they have received a pre-hospital transfusion. And of the remaining 2,854 patients, 2,616 were excluded due to the shock index of less than 1. And out of the 238 remaining patients, 12 were excluded because admission ionized calciumia was not recorded. And out of around 15,547 patients, only 226 patients were included in this study. So the definitions which were used for this particular study were shock index, which is measured by heart rate in beats per minute divided by systolic blood pressure on hospital arrival. Hospital arrival was for shock index. With the shock patients with the shock index of greater than 1 were included in this study, and those with less than 1 were excluded. Ionized hypocalcemia was defined as calcium level of less than 1.11 millimoles per liter, and for severe hypocalcemia, it was taken as 0.8 millimoles per liter. Acute traumatic coagulopathy was defined as an INR of greater than 1.5. So the data which was collected was subjected to statistical analysis, where continuous and normally or near-normally distributed data was summarized using the means with standard deviations, and the differences were assessed using the student's t-test. The skewed continuous variables as well as the ordinal variables were summarized using medians, and the differences assessed using the Wilcoxon rank sum test. The categorical variables were summarized using counts or proportions, and differences assessed using the chi-square test, or if value was less than 5, Fisher's exact test was used. And the association between the variables and binary outcomes of interest was assessed using the odds ratio and presented with a 95% confidence interval. The variables demonstrating some association with the outcome of interest, that is with a p-value of less than 0.1, were entered into multivariate logistical regression analysis to determine independent associations, and these were presented using adjusted odds ratios. So after that, the area under the receiver operating characteristic curve, that is AUROC, was used to assess the discriminatory capacity of the model, and Hosmer-Lemshow goodness of fit p-value was reported to determine whether the observed event rate matched the expected event rates in the model population. The variance inflation factor was reported to exclude multicollinearity in the model, and the timing of death was displayed using the Kaplan-Meier survival functions with patients censored on death, and a p-value of less than 0.05 was defined to be statistically significant, and all the analysis was conducted using Strata version 113. So as you can see from the results, out of a total of 260 patients, around 113 patients, that is 50% of the patients on admission had ionized hypercalcemia, of whom only 2.6% of them, that is 6 patients, had severe hypercalcemia, that is less than 0.8. So among the hypercalcemic patients, 45.4% of them were coagulopathic, while among the complementary cohort, coagulopathy was detected in only 13.2% of the patients. Hypercalcemia was significantly associated with the coagulopathy on arrival to the emergency with an odds ratio of 5.5. And the variables associated with hypercalcemia and coagulopathy were ISS, GCS, bicarbonate, and lactate. The admission ionized hypocalcemia was independently associated with coagulopathy on arrival to the hospital with an adjusted odds ratio of 2.9. The admission ionized hypocalcemia was associated with any blood transfusion and in the first 24 hours post admission in 75% of the hypocalcemic patients compared to 45 of them in the normocalcemic patients. So those who were previously having ionized hypocalcemia at presentation were even more likely to have hypocalcemia after transfusion. This is as expected, and the hospital discharge, 29 or 25.6% of the hypocalcemic patients were dead compared to 17 of the normocalcemic patients. So irrespective of whether they were transfused or not, what they have found was that the patient, the ionized hypercalcemia at presentation was a major mortality associated risk factor. So the clinical feature variables which are associated with hypercalcemia, as we have previously discussed, was with a injury severity score, was associated with the injury severity score, mode of transport, that is, as we expected, those patients with severe trauma were more likely to be brought in with a helicopter rather than with a road car. The initial systolic blood pressure, initial GCS, bicarbonate, lactate, and INR. So so all these variables were found to be associated with hypocalcemia, and these associations were tested with univariate analysis for coagulopathy, and it was found that injury severity score, that is more than 35 or more than 35 was associated with coagulopathy. GCS of less than 12, that is 9 to 12, as well as less than 9 was associated with coagulopathy, and decrease in bicarbonate and lactate was also associated with coagulopathy when assessed using univariate analysis. However, when tested with multivariate analysis within these variables, injury severity score of greater than 45 was associated with more associated with coagulopathy, and GCS of less than 9 was associated with coagulopathy, and also bicarbonate was associated. However, lactate was ruled out as a cause of coagulopathy. And the survival function, when assessed using Kaplan-Meier survival estimates, it has been found that there is a difference in mortality between the patients who are normocalcemic and hypocalcemic, and the horizontal gap which we can see here shows that the survival of the patients who are normocalcemic was higher than those with hypocalcemia, and even the vertical difference between at a particular point of time, for example, if we take at 10 days, 20 days, or at 30 days, was significantly different between those who were normocalcemic and those who were hypocalcemic at presentation. So among the critically injured adult patients with a shock index of greater than 1, hypocalcemia was a common observation, being present in more than half of this patient cohort. And this derangement was independently associated with acute traumatic coagulopathy after adjustment for the injury severity by ISS, GCS, and biochemical measures of acidemia. Hypocalcemia was also associated with higher rates of blood transfusion administration and with a higher mortality at hospital discharge. A study by Magnotti et al. Has shown that low ionized calcium levels of less than 1 millimole per liter at admission were associated with increased mortality of 15.5% compared to 8.7% in normocalcemic patients, and as an increased need for both multiple transfusions and massive transfusions. This is correlating with the present study. The study by Cherry et al. Also had a similar study results, which showed a mortality was significantly increased with those patients with ionized calcium of less than 1. This is 26.4% compared to 16.7% in the normocalcemic group. And the time to death in those patients who are hypocalcemic was significantly shorter, that is 0.5 compared to the 1 day in those patients who were normocalcemic at presentation. So the study by Hokem and Leonard et al. Was showed that the relationship between the lowest ionized calcium concentration during the first 24-hour period of critical bleeding and hospital mortality was also showed that hypocalcemia was common and had a linear concentration-dependent relationship with mortality. With an odds ratio of 1.25 and 95 with a 95% confidence interval, and hypocalcemia accounted for 12.5% of the variability and was more important than the lowest fibrinogen concentration, acidosis, and lowest platelet count in predicting hospital mortality. Study by Kyle et al. In the Royal British Military Hospital in Afghanistan between 2010 and 2014 in 297 patients who were requiring blood transfusion has shown that in the non-treatment group, that is, they have actually divided it into two groups. One was a treatment group and the other was a non-treatment group. In the treatment group, they had given prophylactically calcium gluconate, and they have seen that, there was a difference in mortality between the treatment group and the non-treatment group. And the non-treatment group, 70% were hypocalcemic compared to the 28.3% who were hypocalcemic in the treatment group. And the dose response between the calcium levels of the blood products was significantly high, and with the 1 unit transfusion of PRBC decreasing the ionized calcium to around 1.12, which was manageable, but 2 or more PRBC transfusions was associated with significant hypocalcemia. The limitations of this present study was that it was a retrospective study, done at a single study with a very small cohort of around 226 patients, and there was limited known confounders which were actually assessed. For example, and the data limitations, the type of injury, the manner of injury were not considered. The fluid management which was given prior to the calcium measurement was also not included in this study. And the patient factors, including comorbidities, prior medical conditions, medications, example, if the patient was on antiplatelet drugs, anticoagulants, and all were not considered in the assessment of this in this study. So the critical appraisal was whether this whether qualitative approach was appropriate for this study, while RCTs in this aspect would have been better, but there is a huge paucity of data in this area, especially even in trauma-induced, even in transfusion-associated coagulopathy. Also, there is a dearth of RCTs. Which are actually which can predict the mortality in this particular age, in this particular patients. And so whether qualitative approach was appropriate, we don't know, but it is the only method which is available at present, because any controlled trials or anything will not be possible due to the ethical considerations. And the sampling strategy was whether the sampling strategy was appropriate for this approach. Ruling out all the ruling out all the associated factors. They have selected a specific group of patients who have been studied retrospectively, and the strategy, whether will not be able to comment completely on the sampling strategy because many of the confounding factors have not been excluded or have not been compared between these two groups, and appropriateness of data collection methods. So the retrospective data based on hospital records. How much of it is reliable is always questionable. But in advanced countries, in developed countries, we consider it to be appropriate, and most of our studies based on retrospective data are based on collection of hospital information from the hospital information systems. Data was analyzed using proper, definitely using proper methodology, and statistics was properly used, and the results do make sense because coagulopathy in traumatic patients is a known phenomenon, but those presenting at hypocalcemia in patients who are presenting to the emergency department is also which is need to be considered in the future whenever we are making any protocols. And the conclusions which are drawn from these results, that others have concluded that the hypocalcemia is present in a majority of patients who have come to the to the emergency department, which has been justified by the results which have come up from the study itself. And whether hypocalcemia at presentation results in mortality as well as in coagulopathy has also been assessed using multivariate analysis. So that was also suggested that it was usually associated with coagulopathy, as well as the statistical models which have been used. For example, the admission using the AUROC model, the AUROC for this model was 0.88, which is closer to one. So it is supposed to be it leads us to a conclusion that it is hypocalcemia at presentation results in coagulopathy in these patients. Hosmer Lemshow goodness of fit p-value is also 0.9, and the mean variance inflation factor was also 1.53. All of this suggests towards the robustness of this study, of this trial, and support the justification of the conclusions based on these results. And are these transferable to the clinical settings? Definitely. And so what we have here is a hypocalcemia was associated with early death and also early resuscitative measures involving blood transfusion, especially in early institution of frozen plasma and massive transfusion protocols are likely to further exacerbate the hypocalcemia. Trauma patients receiving massive transfusion are at a higher risk for hypocalcemia and its associated coagulopathy, and may benefit from protocolized prophylactic calcium replacement. However, the calcium replacement in all the shock patients during trauma resuscitation needs further studies, because even though we have seen that hypocalcemia at presentation was present in most of these patients, it can be easily detected by a point of care testing, and calcium can be corrected after detection of hypocalcemia instead of depending on prophylactic replacement of calcium. Thank you.
Dr. Rizwan, I would request you to take over.
Yeah. So excellent presentation. If the organizers wish, we can have the question answer session of both the patient presentation, or else we can have.
Yes, sir. That would be great. We can have the question answer session at the end after the second presentation. I will just. Yes, sir. So I would request now Rizwan to introduce our second chairperson, and then we'll go ahead with the second presentation. Okay.
Yeah. Thank you, Puneeth, for your wonderful presentation. Due to paucity of time, we would have the second presentation, and I have a common question and answer. I request Dr. Aparna, who is also a scientist at the Indian Council of Medical Research, to introduce the second speaker for the day. Ma'am, please take over.
Thank you. Thank you for inviting me to this very invigorating young forum. So Dr. Athira, she'll be presenting the study on convalescent plasma, which was conducted by ICMR and done by multiple sites. Many of our PIs are present in this meeting. So we would like to see what you think of the study and then what you learn from it. Please go ahead, Dr.
Thank you, ma'am. So good evening, everyone. So I take this opportunity to extend my sincere gratitude to the entire YPF team for lending me this platform. And I am extremely privileged to have Dr. Aparna Mukerjee, ma'am, the corresponding author of journal I am to present, for chairing this section. So I myself, Dr. Athira Sasidharan, third year junior resident from the Department of Transfusion Medicine, Jubilee Mission Medical College. So I am here to present the journal titled Convalescent Plasma in the Management of Moderate COVID-19 in India, an open label parallel arm phase 2 multi-center randomized control trial. So the authors of this journal are Dr. Anup Agarwal, Dr. Aparna Mukerjee, Dr. Gunjan Kumar, Dr. Pranab Chatterjee, Dr. Tarun Bhatnagar, Dr. Pankaj Malhotra, and Placid Trial collaborators. So in this section, I will be discussing about introduction of COVID-19, background and rationale, research question, aim of the study, materials and methods, results, discussion, limitation, and conclusion. So moving on to introduction, COVID-19 is an infectious disease caused by severe acute respiratory syndrome, coronavirus 2. The disease was first identified in December 2019 in Wuhan province of China and has spread globally, leading to 2019-2020 COVID-19 pandemic. So about the Indian scenario, it was on 30th January 2020, India reported its first case of COVID-19 in Kerala, and that was in Thrissur. As of 10th October 2020, India has a confirmed total cases of 69,79,423 cases and total recovery of 59,88,822 and deaths of 1,07,416. So how to treat this condition? Currently, there are no universally accepted treatment modalities, either in the form of an approved vaccine or in the form of antiviral therapy. So the management of COVID-19 includes isolation, symptomatic management, supportive care using oxygen, mechanical ventilation, and numerous experimental measures are there with using antiviral drugs, antiretroviral therapy, hydroxychloroquine, remdesivir, and convalescent plasma therapy. So what is this convalescent plasma therapy? The concept of convalescent plasma therapy is not a new thing. It was previously being used for treating cases like Middle East respiratory syndrome, severe acute respiratory syndrome, chikungunya virus infection, Ebola virus infection, and Zika viral infections. So this convalescent plasma will be containing neutralizing antibodies against these viral particles. So in COVID-19 also, the anti-COVID-19 antibodies from a recovered individual can be passively infused in the body of these COVID-19 patients who is unable to produce antibodies in a very effective manner to treat the disease. So numerous studies have been undertaken about this convalescent plasma therapy, and these are some of the journals. This was a published in the journal Chest Journal about a small series of 4 patients in one pregnant woman, and all those 4 patients recovered following convalescent plasma therapy. On the right side, we'll be seeing effectiveness of convalescent plasma therapy in severe COVID-19 patients. This was published in China. And in this study, they observed that there was significant increase in the neutralizing antibodies and disappearance of viremia within 7 days of convalescent plasma therapy. And there was rapid symptomatic improvement within 3 days following convalescent plasma therapy. So even though there are so many studies about this convalescent plasma therapy regarding the effectiveness, but it is not yet proven. So FDA has granted a temporary authorization for this therapy as an experimental treatment in severe or acute life-threatening cases of COVID-19. So what is the current status of this convalescent plasma therapy? It is still under experimental phase and has not undergone enough clinical studies to prove its safety and efficacy. So along with the present modalities of therapies that are attempted, this also requires a lot of research and testing to validate it for general use. So till then, the use of convalescent plasma should be restricted only to actually indicated population of patients, and it should never be used for prophylactic purposes. So it is a background and rationale for this study. As of now, there are only 2 randomized controlled trials which are published. One is from China and another one is from Netherlands. But both the studies halted prematurely due to inadequate patient enrollment. And in both these studies, there was no mortality benefits. So Indian Council of Medical Research initiated a multi-center randomized controlled trial titled a phase 2 open label randomized controlled trial to assess the safety and efficacy of convalescent plasma to limit COVID-19 associated complications in moderate disease. So the research question in front of them was, is the convalescent plasma therapy effective to reduce mortality in COVID-19 patients? So the aim of the study was to determine the effectiveness of using convalescent plasma in moderately ill COVID-19 patients admitted to hospitals across India, and also to determine the short-term adverse effects. So the study design was a multi-center randomized control trial. The study started on 22nd April 2020 and finished on 14th July 2020. And the study they performed in 39 tertiary care hospitals across India, out of which 29 were teaching public hospitals and 10 were private hospitals. So about the inclusion criteria, they enrolled the patients who are having confirmed COVID-19 using RT-PCR methods with at least age of 18 years, who are admitted in those participating hospitals. And they selected moderately ill COVID-19 patients with certain parameters like PaO2 by FaO2 ratio between 200 to 300, or respiratory rate of more than 24 per minute, or SpO2 of less than 93% in the room air. And the patients were also enrolled if there is an available matched convalescent plasma donor at the time of enrollment. About the exclusion criteria, they excluded all the pregnant and lactating women, patients with non-hypersensitivity to blood products, recipients of immunoglobulin in the last 30 days, PaO2 by FaO2 less than 200, and shock patients. They all excluded from this study. About the convalescent plasma donors, they selected either males or nulliparous females with age range of 18 to 65 years with a weight of more than 50 kg. And these convalescent plasma donors must be asymptomatic, confirmed COVID-19 using RT-PCR with at least symptom of fever and cough, and who also have been resolved over a period of 28 days or 14 days prior to the donation with at least 2 negative RT-PCR results, which is done 24 hours apart. And in these convalescent plasma donors, they did routine screening tests like ABO blood grouping, RH phenotyping, complete blood counts, screening tests for HIV, HBV, HCV, syphilis, and malaria, and total serum protein level was also done. Then they did randomization and masking in all these participants. They used stratified block randomization and allocated participants into 1:1 ratio. And in one arm, it was considered as an intervention arm, and the participants were around 235, and under the control arm, there were 229 participants. So the control arm received the best standard care of treatment, and the intervention arm, they provided convalescent plasma treatment along with the best standard care of treatment. So about the procedure, for the control arm, treatment provided was best standard care of treatment. So what is this treatment? This treatment is based on the guidelines issued by the government health authorities. And this included antivirals, hydroxychloroquine, remdesivir, lopinavir, ritonavir, broad spectrum antibiotics, etc., along with supportive management like oxygen, face mask, non-invasive or invasive mechanical ventilation. And for the intervention arm, 2 units of plasma was collected from different donors or from the same donors using apheresis machine. And 20 ml of donated plasma was taken, separated, and kept at -80 degrees Celsius for measuring the and neutralizing antibody titer, because during the initiation of the study, they didn't have any test for detecting the neutralizing antibody titration. So they separated and kept it -80 degrees Celsius. And the treatment provided was best standard care treatment along with the 2 doses of 200 ml of convalescent plasma provided 24 hours apart. And all the enrolled patients underwent clinical examination and laboratory investigations. And these investigations included arterial blood gas analysis, complete blood count, renal and hepatic function test, coagulation profile or day 0, 1, 3, 5, 7, and 14, chest imaging, biomarkers like serum ferritin, LDH, C-reactive protein, D-dimer. Then serum was tested for antibody titer also. Then nasopharyngeal swabs were taken for doing RT-PCR on day 0, day 3, and 7, and all the patients were contacted telephonically to assess the health status. So in the midway of the study, they got the test for doing neutralizing antibody titer, and this was done in NIV Pune. And this neutralizing antibody titration was done in the donor serum and also in the participant serum. And the participant serum, they did it on day 0, 3, and 7. And the titer was considered as detectable titer if it ranged between 20 to 1,280. And if the titer was less than 20, it was considered as undetectable. And if the titer was more than 1,280, it was considered for the analysis. And the outcomes they measured were primary outcome. That means the composite measure of progression to severe disease or mortality within 28 days of post-enrollment. And the outcome was considered as good if the progression to severe disease or the mortality prevented within 28 days of post-enrollment, and considered as poor if it is not. The secondary outcome they measured were clinical improvement on day 7, variation in FiO2 on day 1, 3, 5, 7, and 14, total duration of the respiratory support, negative conversion of viral RNA on day 3 and 7, level of biomarkers on day 3 and 7, then requirement of vasopressor support, clinical improvement on WHO honor scale on day 0, 1, 3, 5, 7, and 14 days. Then safety outcomes also they measured, like frequency of minor and serious adverse events within 6 hours of convalescent plasma transfusion. So they did the statistical analysis using descriptive analysis was done. Univariate analysis was done by chi-square test, then post-hoc subgroup analysis, then intention to treat analysis. Then data analysis was done using Stata V14. And about coming to the results, total 1,210 patients were admitted across 39 trial sites, and out of which 464 participants were enrolled for the study after inclusion and exclusion criteria, and 235 were under the intervention arm, and 229 were under the control arm. 2 patients lost follow-up after discharge from the hospital. 9 patients also withdrew consent after randomization. Baseline demographic and clinical characteristics were similar in both the trials except for diabetes and cough. About the donor characteristics, total 433 donors was there for convalescent plasma collection, and out of which 262 donors was finally used for the trial. And 94.3% of the donors were males, and mean age of the donor was 34.3 years, and median disease duration was 6 days. And these donor population, 94.2% had a mild disease, and neutralizing antibody titer in 63.6% of the donors were more than 20, and the median titer was 40. The plasma was donated after a median duration of 41 days from COVID-19 diagnosis using RT-PCR. And the primary outcome analysis was done in that in the intervention arm and control arm, there was no difference between both arms about the primary outcome analysis, because 13.6% of the patients died in the intervention arm and 14.6% of the patients died in the control arm. About the progression to severe disease, 17 patients each from the intervention arm and the control arm progressed to severe disease, and the composite outcome also, there was no statistical significant difference between the both arms. Regarding the resolution of shortness of breath and fatigue on day 7, it was higher for the intervention arm, whereas fever and cough symptoms, there was no observed difference between 2 arms. About the median absolute reduction in the FiO2 requirement on day 3 and 5 was higher for the intervention arm, whereas on day 7 and 14, it was similar for both the groups. About negative conversion of viral RNA on day 7, it was higher for the intervention arm. About duration of respiratory support, they observed no difference between the 2 arms. And 38 patients required invasive ventilation, and 2 patients survived till 28 days. About the level of inflammatory markers over a period of 7 days, they observed no difference between the 2 arms. And about the adverse events, 1 patient each from the intervention arm and the control arm developed pain in the local infusion site, chills, nausea, bradycardia, etc. And 3 patients each from the intervention arm and the control arm developed fever and tachycardia. 2 patients each from the intervention arm and the control arm developed dyspnea, intravenous catheter blockage, and mortality was 3 patients. And they're saying that it is probably due to the convalescent plasma transfusion within 6 hours of transfusion. So neutralizing antibody titer was done in the transfused recipients, and out of 235, 224 patients titration was done, and out of which 160 participants received at least 1 unit of convalescent plasma with a detectable neutralizing antibody titer. And about the primary outcome analysis, they observed no difference between the both arms who received a convalescent plasma with a detectable titer versus with a non-detectable titer when compared with the control arm. And neutralizing antibody titer was measured in the 418 trial participants also, and 348 had a detectable titer with a median titer at the enrollment time was 90. And enrolled participants with detectable titer and undetectable titer, there was no difference in the composite primary outcome when compared with the control group. So moving on to the discussion, this PLACID trial indicates no difference in 28-day mortality or progression to severe disease in both arms, and there is no difference in the outcome. That means participants who received the convalescent plasma with a detectable titer or undetectable titer compared to the control arm. And convalescent plasma therapy had a higher resolution of symptoms like shortness of breath and fatigue on day 7. And there was reduction in FiO2 requirement on day 3 and 5, but no reduction in the duration of respiratory support. So higher proportion of negative conversion of viral RNA was there for the intervention arm. So this supports the hypothesis of viral neutralization effect of convalescent plasma therapy. And there was no difference in neutralizing antibody titer in both arms despite convalescent plasma transfusion. This suggests no benefit from convalescent plasma collected from young mild COVID-19 recovered donors to moderate to severely sick patients. And this convalescent plasma therapy could not demonstrate difference in the level of anti-inflammatory markers also. This could explain why there is no effect in primary outcome analysis despite early viral RNA negativity. CP transfusion deemed to be safe in this study because 3 deaths, 1.3% of the patients died, and that is probably due to convalescent plasma transfusion within 6 hours. So there are so many limitations for this study because this was open label trial and there will be a bias in the treating physicians. And this was conducted in 39 hospitals. So heterogeneity might come in terms of best standard care treatment and the participant enrollment. And the biomarker assays like LDH, CRP, D-dimer was done by different manufacturers. So the results can vary. There is chance of selection bias also because pandemic was in different stages across the country and the enrollment strength also varies from site to site. And this could not measure the antibody titer prior to the transfusion because of the unavailability of commercial test kits during the initiation of the study. So about the conclusion, although the use of convalescent plasma improved the resolution of shortness of breath and fatigue and reduction in the FiO2 requirement in the first week and negative conversion of viral RNA, it could not reduce the 28-day mortality or progression to severe disease in moderate disease. So future research is warranted to validate its use in COVID-19. So thank you. Thank you so much.
Thank you, Dr. Athira. That was a very nice presentation. And I would just like to add that there are another RCT which has come up now from Spain, but that is also not complete. So that also that does not show any statistical significance between the two arms in case of mortality, but yeah, but that is an incomplete study because they couldn't actually finish the enrollment because there was a fall in the number of patients. So we actually do need to have more of meta-analysis at this point so that all those studies can be pooled and then we could actually say what is happening. So I guess we can open for question if my other esteemed chairperson thinks so.
Yeah, the floor is open for question and answer for both the speakers. In case there are any from the audiences, you could kindly raise your hands at the Zoom. So we would be there, or you could just leave the question even in the chat box. We would take them up.
I think Rizwan, 1 or 2 questions have come in the chat box. So you can start with those questions first.
So with the permission of the chairpersons, I would like to put forward one question, which from Dr. Naveen, when he has asked to the first speaker if any adverse effects of routinely are seen by adding calcium to trauma patients.
Sir, one thing, ionized hypocalcemia prophylactic correction of it has not been done until now, sir. And the others did not study them, nor have they advocated for it directly. So what the study only states is that that might be considered in the future. But even then, prophylactic calcium therapy, I think it is not required because, I mean, anyway, we have point of care testing for calcium levels available at most trauma centers. So, I mean, whether how much of it will actually cause hypercalcemia or whether it will be resulting in any complications and all has not been answered by this paper, sir.
So there is another question and a comment from Dr. Sunil, which says, which congratulates the ICMR for the Placid trial. At the same time, he is curious to know if the trial concluded that convalescent plasma does not require reduces 28 days mortality or progression from moderate to severe disease. Do you think it is right that convalescent plasma should continue to be used as off-label therapy? When and how will convalescent plasma therapy be considered proven for it to be no longer considered an experimental therapy? So,
would you like me to answer? This is for me or the speaker?
I think both of you can take a choice. Ma'am, it would be glad if you would like to take the lead. That would be hearing from the horse's mouth, ma'am, please.
Okay, so if we consider that the plasma that is being given as it is given now, then we can say that it really doesn't have much effect in the ultimate mortality or progression to severe disease. Because in most of the cases, it is being given without actually measuring the neutralizing antibodies. And even if you do measure, it is not as high as some of the studies are trying to tell you that it should. So to continue it in the clinical guidelines management, I shouldn't comment on that, but there are discussions going on in the National Task Force so that there would be some changes in the recommendations. And as for when it can be actually helpful, if you take into account some of the observational studies that have come up, it seems that the spectrum has shifted from severe to extreme left, and now like it is very early. If you can start plasma within 3 days of symptom onset, and if you have a titer which is as high as 1:1350 IgG titer, which will translate to 1:160 neutralizing antibodies, then there might be a chance that it can work. But then just giving it without measuring the titer and without having very high titer and giving it late in the disease really doesn't seem to affect much. Though we would have loved to, we all want to believe that it is working because we all want something to work, but the numbers and the figures are showing it does not, unfortunately.
Ma'am, as a follow-up question that I received on the chat box is where people would like to know if any subset analysis was done regarding the standard of care in both the arms. For instance, there are a steroid was not a part of regular treatment at the time when the study was initiated, possibly, but some patients might have received steroids. So do you think a subset, or are you looking at it again?
Yeah, if you just go through the paper, about 60% of the patients already were receiving steroid, because steroid is something very commonplace which is used in our ICUs to manage ARDS. And that was even before the recommendations started coming. So I think the Indian intensivists were smart. And besides that, we also have done some studies in terms of remdesivir use, tocilizumab use, and that is equally distributed in both arms, and it does not really affect the primary outcome.
The very basic of this CCP, am I audible?
Yes, sir.
It should be given in the viremic phase. As per our national guidelines, it says it should be given in the moderate cases where the patient is not responding to steroids and their oxygen requirement is going up. I think that's a old kind of old kind of guideline, needs immediate revision, because that is creating a lot of confusion among the clinician, and they wait till the patient do not respond to steroid and think of like giving the CCP, which is a very detrimental. See, early 8 to 10 days is the viremic phase, and later is the inflammatory phase. We have to treat the virus in the viremic phase and treat the inflammation in the inflammatory phase. If we give the steroid during the viremic phase, it will be counterproductive. Maybe a patient will worsen. And our guideline says you have to give the CCP after the trial of steroid. It is not correct. The golden time for giving the CCP is the first 3 to 4 days, maybe up to 8 to 10 days. But beyond, if you think of giving the CCP, there should be evidence base. And during presentation, we have already seen many patients were having already the antibodies. So the getting any benefit in such patients who have already developed the antibodies, they are already in the inflammatory phase, is expected to be zero. It's not the question of severity when the CCP should be given. It's the question of time period. It should be earlier the better. The golden time is early 3 to 4 to 5 days, maybe up to 8 to 10 days. American Society of Microbiology says the viremia goes may up to 14 days, maybe in the severely ill patients. But then but then that time one must check the antibodies whether they are already developed in the patient, and if those are there already in the patient, we don't need to give the CCP. This is what like my logical saying goes. And majority of our antibody testing, rather all, were done after the CCP was given to the patient. So many of them were 63% only had the NABs more than 1:20 titer. It also means 36% of our CCP were not having even the detectable neutralizing antibody. So how do we expect the results to be there in such patients? The basic of this CCP or the trial, the very foundation of this trial is the antibody level. If that particular foundation is not built up very strongly, we do not expect the result to come in favor of the CCP. I think this is the crux of the our failure of the this or the showing the negative or the no results of the CCP in our trial. I think that maybe with the authorities present here can address. And there are just not the neutralizing antibody. It is not practically possible to be on the field, but then there are some surrogate markers. SVNT surrogate viral neutralization test can easily be done, and the other if RBD antibody, if it is possible to be done, it is a good surrogate marker for the viral neutralization test.
Thank you, sir, for your wonderful insight. We have got a couple of questions, and Dr. Sunil has got some questions too. Kindly unmute yourself and put forward your questions.
Thank you, Dr. Rizwan. I'll come in here. My name is Dr. Sunil Rajadaksha. I come in here as a representative of the transfusion specialists. And first of all, let me really be very grateful to ICMR for coming up with such a very important clinical trial, the results of which we have been awaiting for many months. And I say this today because clinicians and transfusion specialists are today in a complete dilemma. There is confusion galore. Despite the Mayo Clinic trial with 35,000 patients and the US FDA permitting expanded use, compassionate use of plasma with very good results in whatever way that they got. I'm not discussing that, but I'm here because, we have taken this issue right up to the national level, from the Maharashtra government, from the health secretary and minister to the health minister at the national level, along with the health secretary who responds to the health secretary of Maharashtra saying that off-label use, 1:640 titer has to be done of antibodies, IgG, not neutralizing. No assays available in India. When the question is put forth saying no assays available, the health secretary says, oh, we need to know from ICMR. It's been more than 6 weeks now that they have not said what the ICMR has said. This question, ma'am, to you now is, many of them are not doing or administering off-label or issuing from the blood banks because there's a clause from the DGHS and DCGI saying that you cannot issue convalescent plasma without a titer of 1:640 of IgG antibodies, the assay for which is not available. Which means what many blood banks are doing amounts to violation of the norms reinforced and endorsed by the health secretary at even the national level. We need clear-cut guidelines, ma'am, for everyone's benefit because we're in a pandemic. Patients are dying day by day. They're not getting convalescent plasma because we don't know whether we are violating norms or we don't know level of antibodies, and there's confusion galore. I'm here, I'm thanking Dr. Aparna Mukerjee, one of the main co-authors of this particular playset trial, which India and the world was looking forward to give answers. Directors and deans of all institutes are saying you will not do it because ICMR has said does not reduce mortality, does not prevent progression to disease. So I will just ask you, ma'am, to give us insights into what exactly you think should be done. What will ICMR say on the 1:640 if it is not available? Should we not do it, which is not your purview, but should we not do it? Or should we do it? Or should we do it and give it, though it's violating norms?
Thank you, sir.
Thank you, ma'am.
Thank you, sir, for your input. I'm sure there are several questions even in the chat box. Ma'am, would you like to respond to any of them?
If you want, I can, but this is going to go on. The thing is, it's not ICMR's purview actually to give out treatment protocols, that is Ministry of Health and Family Welfare's work. But if you talk of 1:640, as I said, if you, what I'm trying to say is that if you just give plasma without measuring the antibodies, and as such, it's not going to have an effect. It is anecdotal that you think that it is having an effect, and we all really want to believe that it is having an effect, but the figures are not showing that it is having an effect. And the 35,000 patient number that you are saying, that is not a trial, that is emergency use authorization, and all of them were given plasma. So how do you know that it is plasma that actually helped them? So, and as of 1:640, now presently there are some quantitative ELISA assays that are coming into market. You could do that, or you could do the CLIA, that is the that will give you a surrogate marker of the IgG, and then which is a surrogate marker of the neutralizing antibody. So I agree, the whole situation is very, very difficult, and I guess there will be some management guideline change very soon.
Okay. How many days you spent in hospital?
All the physicians or clinicians, they are looking forward towards ICMR or DGHS to give us the guidelines, and those should be dynamic guidelines, not that once printed are there forever. And since the evidence is very clear in present days, the earlier the better. It should not be given in the late phase, inflammatory phase. The very clause or the very guideline of like transfusing the CCP in the moderate phase after the trial of steroid, that must be scrapped as early as possible. So that is very urgent request I would like to like put forward with limited knowledge. And the dose which we are giving at present, I am giving like kind of plasma of aliquots of 200. USA is advising the alicot of 500 ml. Unless there is a adequate antibody and adequate volume of the CCP given, we don't expect the viral count to come to zero. American Society of Microbiology, in their review clinical article, they have said if the adequate dose of amount of CCP is given with the high titer, it can bring down the viral load to zero within 24 hours. If we are not sure of the titer and the volume also is given, is very less.
Thank you very much.
I think it is not expected, and as per my clinician feedback, what limited is.
Dr. Harish, I'm really sorry to interrupt. I'm really sorry to interrupt. Dr. Aparna had to leave due to some urgent work. We thank Dr. Aparna Mukerjee for giving her absolutely precious time to all of us and discussing this wonderful trial that was done, the first of its kind in India, or I would say this part of the world. I thank you again, ma'am. Dr. Aparna Mukerjee.
Yeah, thank you, Dr. Jindal. And this was possible only because of help of all the PIs like yourself also. So this was very interesting to discuss with you. Thank you for the invite.
Thank you so much.
Thank you.
We would like to just reinforce that the link for the certificates for this webinar is posted in the chat box. Please fill up the link by 5 p.m. today so that the certificates can be generated. And Rizwan, anything else? If it would be, we can pass on the questions directly to the speakers as well as the chairpersons, and the replies can be concluded accordingly.
Perfect. And I would invite you to give the vote of thanks, Dr. Puneeth, for being such a great co-host.
Thank you, dear chairpersons, and for your valuable time and very valuable inputs for this journal club session. I hope some of the queries have been answered, and those which are still there, they can be answered directly through the chairpersons. We will communicate through email to the chairpersons about the questions. And for the students, I hope it would have been a great learning experience to present a journal club on this forum. And once again, I thank my team of Young Professional Forum for supporting us in this initiative. And I would also like to thank ISTM for supporting us through this initiative. With this, we conclude the session for today. And please do fill up the Google Forms for the Journal Club certificate. And see you on next Wednesday at 3:30 with a new session. Thank you. I conclude.
I would just want to remind everybody that we are going to meet next Wednesday at the same time, same slot, for a webinar on patient blood management by Dr. Archana Bajpai from AIIMS Jodhpur. In the same breath, again, I would want to thank Dr. Harish Warbhe and all of the dignitaries who joined us from across the country. We've had a momentous event because we had more than 188 participants. And thank you, Dr. Puneeth, thank you, Dr. Rizwan, for leading this. They are the lions that we have. Thank you so much.
Thanks a lot for the kind words. And the best part is we have completed in time within an hour.
Thanks, Akash. Very nice programs. Thanks all the team, Young Forum, for undertaking this project of Journal Club. Very good. Thank you very much.